Alrighty, folks, we're back with Stephanie. Stephanie, thanks again for joining me and sharing your cases with our audience. We're going to go to a second case, and why don't you get to it?
So this was a case where, on initial presentation, my first thought was vertical root fracture, but didn't necessarily turn out to be that way.
Okay.
So the patient was a 37-year-old male who presented to our clinic on December 1st, 2022 with the chief complaint that my tooth has been hurting and I think it might have fractured. The patient had felt 10 out of 10 throbbing, spontaneous pain, and started to feel swelling around the tooth and within the lymph node at the end of November, but because of work, he wasn't able to make it in until December. So the pros resident had called in Augmentin 875, 125 milligrams every 12 hours for 7 days and recommended ibuprofen and Tylenol for pain. He was offered an emergency appointment, but wasn't able to come in. So when I saw him, he said he had been taking ibuprofen and Tylenol intermittently for the pain, depending on what he had available. He was not able to bite, and he wasn't having any sensitivity to hot or cold. He's a fisherman, so he goes out to sea for about 5 days at a time, and it takes about 24 hours for him to come back to shore. So not always a lot of access to, medications and that sort of thing. So his pain scale when he presented was at 10 out of 10. So in doing the extraoral exam, I did feel some slight swelling under the mandible near the angle and kind of around the inferior border of the mandible, but the whole inferior border of the mandible was palpable. He was wearing a hearing aid on his right ear, so the lymph nodes that I felt, I thought maybe could be the submandibular nodes there. There was some swelling around number 31 on the buccal gingiva, and his oral hygiene overall was poor. Oral cancer screening was negative. So on radiographic interpretation, number 31 had been prepped for a coronal restoration with some recurrent decay. It was missing the temporary crown, and there was a J-shaped periapical radiolucency with furcation involvement. And then we took a 3D scan of the tooth just to further assess. And we can kind of, appreciate the size of the lesion in the sagittal view. And then in the coronal view, we can see where the cortical plate was a little bit broken through due to the lesion, and I could feel some of that swelling intraorally on the lingual side there. So knowing that the infection is draining to the lingual is important because it puts him at a higher risk for a more serious infection. Something to be aware of, Ludwig's angina, is when the submental, sublingual, and submandibular space are all involved, and it can be a life-threatening condition.
Yeah, exactly. And a lot of this has to do with the mylohyoid attachment as to there's always a more lingual orientation of the apices of these posterior teeth in the mandible, and depending on how long the root is and where is the mylohyoid attachment, you're going to end up either in a sublingual or submandibular space, which will make a big difference in terms of the progression of the infection following the path of least resistance. So in this case, based on the image, was that in submandibular space, right? Or was it sublingual?
So I believe it was sublingual, kind of based on what I saw.
Yeah, it was an elevation of the floor of the mouth and so on when you were palpating.
Yeah, just a little bit up, a little bit over there. He had previously taken the Augmentin, so I think it had, decreased, to where it was definitely manageable.
And that's the key thing, is when you have this kind of a tilting to the lingual side, any type of a buccal drainage is not going to work. This is where you're actually going to have to do, if you're going to end up having to do some kind of drainage, it'll have to be on the lingual side, applying suction deep onto the floor of the mouth to get out that infection. And also in terms of apicoectomy and things like that, that's where the CTs have really changed the game now, right, Stephanie? Because now you can look at that nice little coronal section and find out where the root is vis-a-vis the cortical plates and whether it's accessible buccally or not, right? Another thing that we were recently talking about also, the CBCT in this case is very helpful also for anesthesia, where you see a root that is very far lingually oriented. Instead of giving a buccal infiltration to anesthetize this patient, you need to give a lingual type of a infiltration to anesthetize, with the idea of just aiming for the apex of the root lingually through the floor of the mouth. You do that after giving your regular lingual anesthesia during the block. You do that at the end, so they're already a little bit numb there, but they won't feel that. But go ahead.
So we did some diagnostic testing on the tooth. Number 31, there was no response to cold, percussion positive, palpation was positive on the buccal with swelling visualized, and also swelling felt on the lingual, positive with the tooth sleuth. And then there was an isolated 15 millimeter probe depth on the mid buccal with furcation involvement and lots of bleeding on probing. No mobility associated with that tooth, and there was the periapical radiolucency seen on the radiograph. So we diagnosed it as pulp necrosis with acute apical abscess with a differential for a vertical root fracture, or maybe some endoperiolesion, the etiology being some caries or possible possible fracture. Recommended a root canal. Alternatives are extraction and do nothing. His disposition of the patient was a root canal, and for the restoration, we recommend a crown, possibility of crown lengthening with a favorable prognosis. So we went ahead and initiated the root canal treatment that day. We were able to get patency on all 3 canals, and in the distal canal there was some purulent exudate seen, and I did some apical gauging and worked that up to a 4502 with the hand files just to make sure we were really cleaning the apex there.
Very nice.
So then we brought him back 2 weeks later. So this was the initial presentation with the swelling on the buccal, and you can see the probe depth really falling into that isolated pocket there, and the caries here from where the temporary crown had.
So just after calcium hydroxide therapy, you managed to close up that pocket by having done adequate pulpectomy, which involved getting yourself to a nicely gauged apical diameter that cleans the biofilm adequately down there. So that's great. It just goes to show that obturation alone is not necessary for success. It's the combination of your instrumentation and proper chemomechanical instrumentation that creates most of your success, right? So terrific.
Yep, so when we brought him back, the probe depth on number 31 on the buccal had healed. It was back to 2 to 3 millimeters, kind of very similar to around the rest of the tooth. So we went ahead and obturated since that had healed. And the patient followed up with pros and got a new temporary crown and is in the process of getting his new crown and kind of continuing that full mount treatment with them.
Terrific. And after follow-up, the patient's healing well now, right?
Yep.
No symptoms.
No symptoms. Everything seems to be well with him. We're just kind of following up long-term to make sure that that bony lesion does heal.
Yeah, that's terrific. Again, follow-up is critical in these kinds of cases to make sure everything heals well. But I think the lesson here, Stephanie, as you were kind of alluding to, is that J-shaped lesions themselves are not an indication and deprobing that the fracture is present, especially in cases where you have larger canal volume. Studies have shown that the larger the canal volume, when it gets infected, the larger the lesion, and the more, because you have a higher volume of biofilm and bacteria inside the tooth. So it's important to kind of recognize that, and then the antidote to that is making sure that you really do reach adequate diameter to touch those walls in these wider canals so you can get adequate cleaning of the apex, and in combination with proper instrumentation, chemomechanical instrumentation and calcium hydroxide when it's needed, that bone in the furcation, it's very different, right, between periodontal disease. What do you think is one of the differences, for example, between endodontic disease and periodontal disease?
Well, in endodontic disease, the bone is confined, it's not exposed to the oral cavity, whereas in periodontal disease, it's exposed to all the bacteria within the oral cavity. But by us kind of cleaning out that bacteria through the root canal, it can allow the body a chance to heal that bone in without that stimulating factor.
I mean, we're talking about fascial space infections that follow the path of least resistance. Apical infections do the same thing in a sense that, especially in lower second molars, where you have a proximity of the mesial and the distal roots, that bone that's sandwiched in between in the furcation is fairly small and thin, and that's a path that the microbes can actually dissolve through. So you end up losing the furcation quite a bit in these lower second molars. Now the problem is that they're also the common cause of vertical root fractures in the lower second molars. But they also, you lose the bone for these reasons as well, so you don't know, because one will respond very well to root canal therapy and the other one doesn't. So in the absence of your exploratory procedures not showing any cracks or fractures that are mesiodistal cracks, it's fair to assume that it is just an endodontic lesion, which also shows that unless you've seen that vertical fracture, you should not assume that there's a vertical fracture, because it could just be endodontic lesion. And the origin of that is the apex. So if you do endo, that bone will come back, as opposed to periodontal lesions in the furcation, where the origin is not the apex, it's the root surfaces. So that bone is not going to come back because the root surfaces are generally contaminated at that point. So it's a great educational case. When you see J-shaped lesion, right, Stephanie, don't just automatically say it's a crack or fracture has to be extracted. Validate the presence of a crack or fracture. And I think you took care of this case very nicely, and I'm sure this guy's out to sea fishing now and enjoying his tooth. Great job. Thanks for bringing these cases. They're very educational. Guys, comment below with any questions that you have for Stephanie, and thank you again for joining me.
Thanks.
We'll see you in the next video.